You're very astute and come and clarify. So when we talk about treating a headache with a migraine cocktail, and I say NSAIDs, we're pretty much doing IV. And the only IV NSAID really that we use a lot is Torlac. So Toradol, anywhere from 15 milligrams to 30 milligrams max is what we're looking at IV. If you give that IM, you can do up to 60. So, and the metoclopramide is not necessarily designed as an antiemetic. What they found is it does amazingly treating headaches. Okay, just got to prevent those akathisias with the Benadryl. And the Benadryl is given IV because we use that very commonly with anaphylaxis. And we'll end up talking about that too. So these are just readily available medications in the emergency department that you would be able to find usually in a crash cart. Very easily in a Pyxis. It's not something that has to be special ordered. So you're going to treat a lot of headaches there. So I hope that clarifies for everybody when I say NSAIDs. That's pretty much the go-to with that. And just be aware, there are a lot of people that actually have a allergy to NSAIDs, believe it or not. And we'll go into full-on anaphylaxis. So to get some Benadryl on board along with that Toradol and the medical provider, you're probably moving in the right direction. All right. Get into stroke action.
Now he's been wanting to put garlic chives in everything.
Well, not everything.
Dad, the side of your face is drooping. Mom?
Probably nothing.
Dad, are you okay?
You're slurring. Why are you slurring? Raise your arms up in the air for me.
Dad, are you okay?
Gracie, call 911.
I just
Honey? Tim!
Tim!
Tim, look at me, Gracie. Tell them to hurry. Tim, look at me, Tim. Dad, I think he's having a stroke.
I think my dad is having a stroke.
Tim, what's going on? My husband, he's cold. Are you cold, honey? Are you cold? Okay. Gracie? See, Gracie's gonna come, sweetheart. We're just gonna go in the ambulance right now. We're gonna go to the hospital. Okay? Okay. Huh? I'm right here. Gracie, meet us there. I'm right here. Okay, here we go. You just stay right here. You just stay and breathe. Just breathe. Tim. Dad?
How you feeling?
I'm fine.
Well, you've had a stroke. But because you got here quickly, you're looking at a full recovery.
All right. Just to kind of clue everybody in with what we're going to talk about here as far as stroke symptoms. Why is this important? Because they've done some statistics in the U.S. Stroke happens about every 40 seconds. Somebody dies from a stroke, about one death every 4 minutes. So it's kind of a big thing. Based on your MTF, you'll see if they're good at handling these things. There's certain stroke centers that are getting they're doing a much better job of ambulances and EMS seeing somebody and determining where they need to go based on how severe that stroke is. And that stroke severity is determined by the NIHSS scale. So, and we'll talk about that a little bit. I'm not going to expect anybody to calculate that. I'll tell you, your 6 weeks in the emergency department, at least have it so you can pull it up on MD Calc and be able to run through it. It's not something I expect you to remember all 11 elements and how to calculate that, but we'll talk about it today. Again, here's your reference, I should say, and objectives. They're really important that we can identify. So TIAs is just precursors to strokes. As usually happen events that's just leading up to that transemic ischemic attack. And then we're going to talk about all the different ischemic strokes being the more common of the two, hemorrhagic being much more deadly to you. If anybody's going to have a stroke, not that you get to choose, but ischemic strokes have better outcomes than hemorrhagic strokes. So, just like the video there, we want to make sure we're getting our safety net in place. we need to get them to the CT scanner immediately. So good stroke centers, that person comes in, EMS is already called stroke from the field, that person comes in and they're getting their NIHS stroke scale by the neurology team, by emergency medicine provider on the way to the CT scanner. Is why we need to determine that CT, is it a hemorrhagic stroke or is it an ischemic stroke? If that CT scan says hemorrhagic stroke, we go down a completely different path. You can see that. Prevention of further bleeding. So we're going to control the BP and then hopefully have a neurosurgeon house it go in and take care of that. If the CT does not reveal hemorrhagic stroke, then we're going to say it's an ischemic stroke, and that's where our window for TPA. So TPA, that's going to be thrombolysis inside of the brain. And there's potential based on the size of that stroke. Yeah, neurosurgeon can potentially get in there, but ischemic stroke, most of the time we're going to start TPA, unless there's some significant contraindication. So, and our window, most literature supports a 3-hour window from symptom onset, confirmed symptom onset, to some studies are saying in some cases we can push it out to 4.5 based on the study that you read. So let's, for all intents and purposes, we're going to stick with the 3-hour mark for testing purposes, 3 hours. So, hence, concept number 1. I'm going to give you choices, A or B. A, TPA, B, aspirin. And then I'm going to preface that with, when do we know that the patient was symptom-free? When was the last time that we can confirm that? 10 p.m. So we're way out of the window. I don't know if this lady stroked out 5 minutes after she fell asleep, or if she stroked out 5 minutes before she woke up. Don't know. Guess what? We're not pushing TPA there. Last known symptom onset, guaranteed we have to know that. This is not a candidate for TPA. So, way past the window. Way past the window, like almost 8 hours past. So, everybody good on that? Last time they were known. So, all right. Any disease process interrupting blood flow to the brain, that's considered a stroke. So, we lose the 2 substrates that we need to give the brain the high energy phosphate production that it requires. And then we also have other side effects, sequelae to this, that include cellular injury that causes edema as well as mass effect. So we have different flavors of this, but obviously that's going to cause increased intracranial pressure, which is why we have that edema and mass effect. Here's your all flavors of that. Like I said, majority of these are ischemic. Now, ischemic can be broken down into thrombotic, embolic, hypoperfusion, but then you have your hemorrhagic, which only makes up 13%. Most of those are going to be intracerebral. Most of that's going to relate to high blood pressure, probably being one of the number of risk factors with that. Yes, there is potential for a subarach hemorrhagic stroke. And here we go, just for you visual folks. So just realize thrombotic, most common cause of the TIA, if they're having TIAs, is probably thrombotic. So those are where those wax and wane. Get better, get worse, get better, get worse. And then embolic, just realize that's intravascular material from a remote source. A lot of times that will come from the heart. These people maybe suffer from atrial fibrillation, and they get a clot formation, and that breaks free from the heart and goes to the brain. So about 20% of those. And then you have your hypoperfusion, that's systemic hypotension that causes that. So based on those hemodynamic factors, if that person's hypotense and then go back to normotense, hypotense, normotense, we can see that waxing wane as well. Those are all ischemic strokes. Then we have our intracerebral hemorrhage. You can see major causes there. Number 1 at the top, hypertension, But then we have iatrogenic anticoagulation, vascular malformations, these are usually in the form of AVMs, and then as well as cocaine use. We talked about that, that causes that vasoconstriction. You have your non-traumatic subarachs, those are all zebras. Don't spend a lot of time trying to figure that out. Not. But of course, time is very important. So early detection, super important that we get that. It's going to reduce morbidity and mortality. So time is that critical component. That's why it's so important we need to figure out when they were last known. We can get as quickly as we can to a stroke center, into a CT scanner. A lot of times they encourage family to ride in the rig so they can provide accurate information about when they last and when the patient was there. And like I said, EMS is getting much better. The stroke system is getting a lot better as far as where do they take the patient based on their symptoms, how severe the stroke. Because if they need to have TPA versus getting some endovascular type of therapy from a neurosurgeon where they can go in there and snag that clot. So a lot of times, if there's no family member, well, that's why you need to get in the room as quickly as possible to hear that EMS report. They're going to give as much as they possibly can. These are different pre-hospital stroke scales. I'm going to tell you the only one that I need you to care about is the top one, is the Cincinnati. And that basically just comes out of that cast. You know, facial asymmetry. So, droop, facial droop. So, you need to look for those types of things. That's just a quick one to say, okay, this is probably a stroke. That's just going to be a bystander. I would just say somebody that's not medically trained, that's probably about as good as they're going to get. But we need to make sure that we get accurate diagnosis, focused, accurate HMP. There's your facial droop, arm drift, abnormal speech, that's S, and then T is going to be time. We need to know the amount of time. When do these symptoms start? So just realize there can be some subtle symptoms. And I have a slide here on the next slide, and this is where these present atypically. And I really dislike it when I have patients that come in and they say, I'm lightheaded or I'm weak. I'm just having weakness, generalized weakness. And it's like, what are they really having? You've got to tease that stuff out, but you should always put stroke on there. So, altered mental status. Look at this, 50% of women with new or recurrent strokes tend to report this non-traditional symptoms as dizziness and vertigo. So, like, is this a stroke or is this somebody that's having Meniere's, or is this somebody that's just having some vestibular symptoms? I mean, very different. Is this just somebody that's hypoglycemic, can just get a little wonky? For you visual folks, again, right here, generalized weakness. Unfortunately, women present very atypically, as well as diabetics. So be careful with those. Women will also have silent ischemia in the heart. I get very concerned with that. Just an interesting one, so sudden onset of hiccups for no reason. Sudden onset of hiccups would usually be a stroke. I doubt that's going to be on your pants, but it's a little interesting fun fact. So, how do these present? So, in our embolic hemorrhagic, sudden onset symptoms. Sudden onset with those. And then with that thrombotic hypoperfusion, wax and wane. Another term is stuttering. So, we always get concerned if we have Valsalva with immediate headache or sudden symptoms during strenuous lifting. Very concerning. Don't worry about that so much in younger folks, but definitely in older folks. And then recent neck trauma or manipulation, concerned about a cervical artery dissection. And you think, man, who's had some neck trauma? In case of maybe a car accident. But if we're talking about manipulation, unfortunately, the most times that I've seen this, it has been somebody coming in after seeing a chiropractor and having their neck adjusted. I suppose if you're an MMA fighter, there's another potential right there. But I don't see that many old people in the octagon. So thrombus formation, so blood clot formed, and in situ is within the vascular system. So, and it impeding blood flow. Your other risk factors, obviously high blood pressure, people that are diabetic, and then people that have a history of CAD, coronary arteriosclerotic disease. Obviously, if they can form clots inside of the heart, they can form clots inside of the brain. Make sense? Or just propensity. Why do you think the diabetics? Anybody have an idea why are diabetics in the category? So excess glucose in the body unfortunately causes fatty deposits to form easier. And if fatty deposits are forming inside the blood vessels, obviously we're being more concerned with clot formation. Now our embolus folks, so that can be a blood clot, that can also be an air bubble, piece of fatty deposit, gets in the bloodstream and then lodges, causing an an embolism. So atrial fibrillation, I talked about that. The heart's not beating properly. When you run the risk of forming vegetations and growing clots, valvular replacements, and then unfortunately somebody's had a recent MI, that clot can also break free and then cause a embolic stroke. Back to the warm-up case right here. This is paramount, okay? People still miss this question because I put it on the phase 2 test, and they're still missing it. So, not that many. I think I only had 3 failures since July, but we need to know last time when they were at their baseline. And then we had to rule out these stroke mimics. So seizures, migraine, syncope, sepsis, brain tumor, metabolic derangement. Again, I've seen somebody call a code stroke and then neurology team shows up and then they get a glucose. That's the first thing that the neurology team's going to do is when they walk in. If that patient's coming in by the rig, so they should have gotten a D-stick on the rig. So they go, yes, I do in fact have a stroke, it's not a hypoglycemia. So if you're on the fence, you're like, I don't know, just call it. The 50-50 on a stroke, 50-50 on an MI, call the code stemming, call the code stroke. Rather you mess it up than miss it, okay? Then you mess it up and miss it. But we need to rule out that hypoglycemia right away. So, again, as always, make sure ABCs. Most of the time, you look at a patient, hey, you feeling okay? You can look at them and pretty much tease that out. But we want to exclude those mimics. Start identifying comorbidities right away, medications, history. Why? Because that's going to give us our exclusion criteria a lot of times. So I'm going to evaluate for underlying cardiac or vascular disease, but I'm going to call that code stroke, and then we're going to get as much past medical history, follow your stroke protocol. That's going to be labs right off the bat, usually CT first. At some point an EKG needs to be done, as well as a chest x-ray. And then if you can, right here, this is this National Institute of Health Stroke Scale, NIHSS. Standard for documenting severity of stroke. This is important. It's going to tell you also who's a candidate for TPA and how severe the stroke is. So we have 11 different categories. It goes from a score of 0 to 42. It says quick to use. I don't think 5 to 10 minutes is that quick, but okay. But it's reproducible, very high reliability. So what you're going to do is you can go to that YouTube if you want to look at it, but it's going to look at loss of consciousness, extraocular movements, visual fields, facial palsy, arm droop, leg drift, limb ataxia, sensation, language, and aphasia. Remember we talked about most people are right hand dominant, left side of the brain is language, dysarthria, and inattention. So how does this work out? Right there. No stroke symptoms, obviously 0. 1 out of 4 minor stroke, 5 to 15 moderate, 16 to 20, and 21 to 42 is pretty severe. The majority of those people are going to be at that level are probably not. So specifically breaking this down. Any questions on that right now? No, I'm not going to expect you to calculate an NIHSS. I don't think that I could do it right now without a phone and some use. But just so you know, that's something you can easily pull your phone out, start calculating that. If you can have that before neurology gets down there, they'd be pretty impressed. So ischemic stroke syndromes, we talk about ischemic strokes. We're going to talk a lot about where these strokes occur. Now keep in mind, that just because it occurs, it depends if it's more proximal in that vessel or more distal in that vessel to how much symptoms we're going to see. So we can have a stroke in the medial cerebral artery. If it's more proximal, it's going to be worse. Whereas if it's more distal, it's going to affect less. When I say proximal, you understand what I'm saying with that versus when it starts to switch over. So I would definitely, I don't think I have any questions that relate to this, but you need to know, you will see this probably on your hands. You'll need to know. So you need to know that this is the most common vessel that's involved in a stroke, the middle cerebral artery. So again, more proximal in the artery, it's going to cause more damage. It's more distal to where it's going to switch over to vein and start venous returning. It's going to be not as many symptoms. Does that make sense? Makes sense to everybody? Okay, good. So depends on that the lesion location, and then also which hemisphere is it attacked? Is it in the left or the right? So what do we see with this? Usually hemiparesis, one-sided, facialplegia, usually that same side. Aphasia, very common, and then sensory loss on the opposite side of the body. So motor symptoms here, sensory here. So usually affects the face, upper extremities much more than lower extremities, much more. So here is just an idea of what we're looking at. It's a tiny arrow in there that is the middle cerebral artery, most commonly affected with a ischemic stroke. Now we deal with posterior cerebral artery infarctions, also known as the distal posterior circulation. Anything posterior is going to be less of the hemiparesis and much more symptoms that are going to seem like they are vestibular in nature. So we're going to have things like ataxia. We're going to see nystagmus. Now, the majority of that nystagmus is not going to be left or right because it's a central cause. It's probably going to be nystagmus that goes up and down, up and down. Altered mental status and vertigo. So really need to think about if the patient's having trouble walking, cannot tandem walk, we need to be thinking that this is more of a posterior type of stroke. So it's the lateral cranial nerve deficits with contralateral motor weakness. So this is letting us know it's attacking more of the brainstem, and then obviously it can get a little bit wonky based on whether that's more distal or posterior. We have all these other symptoms: limb weakness, dizziness, blurry vision, headache, as well as slurred speech. So we can have some visual loss, some ataxia, obviously that's going to go with the vertigo, and sensory deficits, and then just that general lethargy as well. And here, if you want to see where that's at, so see where the arrow is at the bottom there, this is the posterior stroke. So most of the time, they will have contralateral pneumonitis hymenopsia, and I will show you a picture of that here in a second, unilateral cortical blindness. I had a patient come in, I think my first week at BAMC, and she pretty much had lost vision from her right eye from here over. Unfortunately, this was a Friday, she loses her vision that night, goes to sleep, figured, just go to sleep and I'll wake up in the morning and it'll be gone. Woke up the next morning, it wasn't gone. By the time she got to me that afternoon, damage was done. She gets her aspirin, she gets admitted to get a full stroke workup. Unfortunately, there's nothing I can do. There's no TPA after that type of thing. It was a temporal artery stroke, but pretty sad. Had she come in initially right after she saw her symptoms, we might have had a chance to save at least part of her vision. I think this is really a wonky thing, so obviously we're going to have some sensory deficits. Loss of the ability to read, but they still have the ability to write. It's really weird. So I don't understand how that works. But naming colors, just some other interesting things. So there's this thing called hemibolismus. So this is a type of chorea. Essentially, they have large amplitude fleeting movements. So they're actually just going like this. Really wonky thing. Look it up on YouTube. Anyway, so here is that visual signs. Here's what they're going to complain of. They're going to lost right down the half, the left side on both eyes, left side on both eyes. So, right, so the brain processes that, but just an idea on how that works. Here's the basilar artery. So, unilateral limb weakness with this. That dizziness is that ambiguous complaints, but they're also going to have dysarthria as well as double vision and a headache. So we need to look at cranial nerve 7 signs. A lot of times this is going to present as if it's a Horner's syndrome right there. So we have Horner's syndrome, possibly correlated with basal artery occlusion. What do we see with Horner's? We see ptosis, meiosis, and anhidrosis. Okay, so they're not going to be sweating, right? Not going to be sweating that particular side of their forehead. So I want to make sure we check that. So basilar artery infarction, give you an idea of where that is. This is just kind of reiterating, but most of the time we look for that Horner syndrome, cranium nerve 7. We're also going to see Levinsky sign, and then dysarthria. This is just kind of showing you where that is attaching. The other sad thing is this can get what I consider probably one of the worst kinds of strokes that I've ever seen before. And this is that basal artery infarction, specifically the middle posterior circulation. This is horrible, very rare, but a locked-in syndrome. That's where the bilateral pontine ischemia. So this is what's known as a catastrophic stroke. Catastrophic stroke. Look at this, complete muscle paralysis, except for you're just staring upwards and blinking. Cannot communicate, but you are completely aware of your surroundings. So I think if I had that happen, that would be terrible, but again, very high risk. This is a catastrophic stroke. Locked-in syndrome, I wouldn't wish this upon anybody. And this is why we do our cerebellar type of neuro exam. So because this comes in sometimes very non-specific, again, that dizziness, because it's affecting the cerebellar, so you can imagine it's going to affect their gait. Starts messing with the vestibular system, so sometimes these people can have some nausea, vomiting, then a whole bunch of other symptoms. Here's where the intractable hiccups can start, sudden onset. So based on where that is, specifically in the cerebellum of the brain, they can be anywhere from significantly alert to significantly comatose. Unfortunately, because that's so posterior in the brain and it's encased pretty much in bone, so CTs sometimes, about 1 in 4 of these come back completely normal. We're like, what's going on? But that's when we start reaching for something called a CTA, or CT angiogram. If somebody comes in with stroke symptoms and you're going to send them to the CT scanner, but they're having some type of ataxia, vertigo type symptoms, dizziness, I'm always going to give a CT, but I'm going to ask for a CTA. It's going to look more in that posterior area, CT angiogram. It's going to look specifically at the arteries that are in the back of occipital area of the head and the brain. So potential for an MRI, yeah, that's going to be neuro making the call if that's what they need, but the CTA, just be aware of that. And the cerebellum is very posterior and inferior, so we need to be very cautious about that. So, very difficult to find, can rapidly deteriorate. These people need neurosurgery consultation if that's suspected or we have it confirmed. And then, has anybody heard of the HINTS exam? HINTS exam, probably something you need to do if you're concerned that they're having a cerebellar stroke. You have some positive finger to nose, you have some positive heel to shin, some positive rapid alternating movement with their gaits off. So HINTS exam is called head impulse. So you can look it up on the internet, but you're basically going to turn the head real quick, and their eyes should stay locked into your nose. Say, look at my nose, you twist your head real quick. If their eyes divert even for a second, and they can't stay locked on, that's a positive. Then you're just going to look for nystagmus. That's usually going to be up and down again. And then we have test askew, and that's simply just covering up one eye. If that eye starts to deviate on its own, cover up the other eye. So that's the HINTS exam. They're saying that sometimes you get good enough of that, you've seen enough of it, it can be life-saving rather than sitting there waiting for the CT or the CTA that 25% of that's going to get missed. So I'm going to move on to this carotid vertebral artery. So we get worried about these in young middle-aged patients. So these are people that have minor neck trauma. So seeing a chiropractor, asphyxiation, and then, you know, if Austin Powers gets you with a judo chop, you gotta worry about that. So, underlying issues, connective tissue disease, you know, Ehlers-Danlos, that kind of thing, migraine history, large vessel arthropathies, and high blood pressure. So not super common, but worry about this in the younger people. I think the one that I've seen on the pantry is somebody's wrestling with their dog, a young person, and somehow like just wrestling around, tussling with the dog, they end up having some neck trauma incoming, and you got to be worried about carotid or vertebral artery dissection. So unilateral frontotemporal headache, so we go back to that. So pulsatile, they're going to have, it's going to be similar to Horner syndrome, where they're going to have that meiosis and ptosis. So can precede other symptoms and go anywhere from hours to days. So CT angiogram is where we start looking at the vessels in the neck, vessels in the neck. So needs CT and a CTA. So here's how that can present. Can mimic these other things. Now it's a partial Horner syndrome, but linked to carotid artery dissection. We need to be very concerned about that. We need to be very concerned about that. That can progress to ischemia, so it can start spreading up into the brain, and then sometimes it can actually spread to the eye because it's in that arena. Versus here's your vertebral artery dissection. Think about the vertebral arteries. Those are going to be in the back of the neck. So again, we're going to start having those symptoms of dizziness and vertigo. Look at that, 58% neck pain along with headache. So this might present, we're like, is this a meningitis? Because they're kind of having neck pain, potentially some stiffness. The headache is going to be very occipital in that area, so you're going to be worried, is this a cerebellar type of thing? So unfortunately, this affects the posterior circulation composing of the vertebral arteries. So again, CT with CT angiography choice, and then that patient comes inpatient, likely going to need either an MRI or an MRA. Any questions on ischemic strokes? I'd say very important. I would probably spend a lot more time studying that, just because that's going to be what's going to come in 9 times out of 10. So 9 times out of 10 versus the hemorrhagic stroke, encompasses 13%, more like 1 out of 10, without splitting hairs. So hemorrhagic stroke. Questions on ischemic strokes? When we get into treatments, it's going to start getting very interesting with who's candidates and who's not. But we'll get into that here a little bit. So, how can this present? Sometimes can be clinically indistinguishable. So you cannot tell, but hemorrhagic, look at that, higher levels of morbidity and mortality. So like I said, these are the more deadly. So what do we get that CT for? We need to differentiate it to determine which road we're going to go down. We're going down the ischemic road or going down the hemorrhagic. So that CT is purely to rule out the hemorrhagic stroke for the most part. And then we just assume then no bleeding, it's got to be ischemic. It's got to be ischemic. So just realize you can have a headache with this, nausea, vomiting, preceding the neurologic defect, deficit. So again, clinically indistinguishable, non-contrast CT. Just keep in mind, low sensitivity, we're looking at posterior fossa infarctions, that's all your cerebellar types of issues. Very difficult to look for those cerebellar infarctions. Like I said, 25% of them will sneak through. If that's the case, and they're pretty sure, with neurological consultation by the bedside, hopefully, they're going to say, hey, I want a stat MRI. You're going to bump somebody out of that MRI suite. So, because MRIs take a long time, so hopefully we can get them over there. That is definitely going to be part of the stroke workup. When a person comes in, after you've got them taken care of, at some point they're going to get ultrasounds of their carotids, they're going to get an MRI of their brain, and get teased up with all the risk factors. So, have a cerebellar hemorrhage, very concerning to catch that, very deadly. And then we can also have the other flavor is subarachnoid hemorrhage. So, usually complaining of an occipital or what's described as a nuchal headache, and where that is usually occurring. So sudden onset associated with straining, heavy lifting, and then also what is called postcoital headache. Subarachnoid hemorrhage, high suspicion, especially after strenuous activity, because the blood pressure is increased so much that it causes a hemorrhage. So, with our diagnosis, we talked about time spring. So our goal, evaluate treatment of patient, usually within 60 minutes. Again, if you're on the fence with this, call code stroke, let neurology be the final guide to that. They would rather you call it as soon as possible rather than waiting. So, Code Stroke, again, I encourage you, when you get to your MTF, before you start your emergency department rotation, get a copy of the stroke protocol. It's going to be a whole packet. Usually one of the techs that's sitting there should be able to print that up for you and look through that, because that's, as soon as you call that Code Stroke, it's just checklist medicine from there, making sure that everything's ordered, all the times are written down. It's a very meticulous type of thing. So how your stroke team shows up, it should include neurology. If you are a big enough MTF, FAMC will have a neurosurgeon go show up, but do not delay. So you want to get that patient moved. If they're out in triage, if they are in a room that's not monitored, let's get them to a monitored room. If you have the ability to a trauma bay, there's going to be a lot of people coming down. It would behoove you to move into a larger room. So, this is, I talked about that continuum in the emergency department. You are evaluating and treating this patient at the same time. So you are diagnosing them, you're focusing your history, your physical exam. So we want to make sure we do that. So EMS, hopefully they've already notified you. They call Code Stroke. You're getting your history physical, determining inclusion-exclusion criteria for thrombolytics on the way to the CT scanner. But we need to right away, again, getting that non-contrast CT. Usually we want the imaging done within 20 minutes or less. 20 minutes or less. The goal is to exclude intracranial hemorrhage. So again, usually not going to see anything for an ischemic stroke. Usually not going to see anything. And then as soon as that's completed, you should probably be over at radiology and saying, hey, can you read this? Can you read this? Usually they're pretty good about that, but within 45 minutes of the patient being there. Why? Because we need to see if they're going to be candidate for thrombolytics. So thrombolytics, if it's an ischemic stroke. Not reaching for thrombolytics in hemorrhagic stroke. Again, that's only if you don't like the patient. Don't do that. So, MRI for acute stroke is limited, so posterior bleed, unless you think it is posterior, we can't get anything. We do not recommend that, but that's going to be in conjunction with that neurology team. So non-contrast CTs, most readily available. It's going to be done within 5 minutes. Only study necessary before giving TPA. So we want to make sure that our patients are oxygenating well. We're going to get probably an I-stat to see if we need to adjust at all, if we're having any evidence of electrolyte or hydration abnormalities. It is also very common for a patient to have a fever. Very common for a patient to have a fever. That is just inflammation of the body from that stroke. So if they do have fever, that's going to be increased morbidity and mortality. This is increased metabolic demand that the body is going to cause it to have some hyperpyrexia. It is okay to treat this. We're not going to reach for NSAIDs. So we're not going to reach for NSAIDs, but we do need to be concerned, is there another underlying issue? Can this person be having a stroke and then also have an infection on board? Absolutely. Absolutely. So I want to do it real quick, make sure we check a UA. Probably good to do at some point a urine exam just to look for any evidence of skin infection, and then a chest x-ray just to make sure that there is no evidence of pneumonia. We treat that only with Tylenol. We do not treat it with NSAIDs. They're not treated with NSAIDs. So I want to make sure that we want to get that temperature lowered. If the patient is not a candidate for thrombolytics or reperfusion, and there's going to be specific exclusion criteria, so if they've had a history of a hemorrhagic stroke, you're not going to give them TPA. So, and if you can't get that blood pressure down, so if they're not a candidate for thrombolytics or reperfusion, we give them permissive hypertension. You should. You really don't want to give somebody thrombolytics when they don't need it. It's a tough thing. So they went to sleep, woke up with a stroke. What time do they go to sleep? Unless it was an hour before, don't mess around with that. So got to look at inclusions and exclusions for this. So also NIHSS score is also a factor. We're looking between 4 and 22, so not severe strokes. Usually not severe strokes when you talk to somebody that's in that category. So it's good to have this calculated. Score between 4 and 22 is what's recommended. Now, let's say it's 23. So we score 23, like, oh, what do I do? I'm going to talk to neurology. They should be at the bedside anyway. We're going to make a decision together. They've seen enough of them. They should have seen enough of them. They should be able to advise you on that stuff. So, right here are your inclusion criteria. This is pretty easy. So we know that it's between usually between 4 and 22. Anything greater than 22 is probably not a poor outcome, probably not going to make it anyway. So, and then we have our onsets, usually less than 3 hours. Onset is less than 3 hours. And then we usually don't push TPA on kiddos, but we usually don't have a lot of strokes with kiddos anyway, but it has to be 18 or older. Here's your exclusion criteria. And this is a lot of stuff, but you're going to have to ask all these type of questions. The ones that I really pay attention to is if they have any symptoms suggesting of a subarach hemorrhage, and then any history of previous intracranial hemorrhage are the types of things that I have usually seen. Now, they say platelet counts of less than 100,000, so thrombocytopenia, which we talked about before. Does it mean that you're going to necessarily wait for that? No, it's sort of a relative contraindication. So, and then any use of heparin within 48 hours. Or PTT. So you're going to need to get coagulation factor from these folks. But here's what we do. Those are the things that I would definitely be aware of. There's a whole bunch of other little interesting things in there. Active internal bleeding. I mean, how are you going to know about that? It's like a tough thing unless they say, oh yeah, I had a GI bleed yesterday. Probably should have been treated. Not likely that's going to be an issue. So make sure you get your bedside glucose before you push that TPA, and then there's your dose right there. So you're going to get 0.9 milligrams per kilogram. 10% of that dose is a bolus over the first minute, and then the rest of it's going to infuse over the next hour. Where does this person go in the hospital? ICU, definitely. ICU because they need to get blood pressure and neuro checks. But if you have them down there and you might hang on to them for a couple hours, you need to be doing making sure. And this should all be in the stroke protocol. And they should be going in there and getting blood pressure and doing neuro checks every 15 minutes. That's probably going to be needed. This is going to take up a lot of your time. No anticoagulants or antiplatelet agents for the initial 24 hours after TPA is given. So hopefully, some hospitals have stroke units. Not a lot of them do. But I hope you get the opportunity to see what a stroke unit is supposed to look like, because they monitor, are very comfortable pushing these strong thrombolytic drugs, and they monitor neuro. So if you give the TPA and we're concerned that there is some bleeding that's going on, we need to stop that. In an emergency CT, we're going to order all these different labs, because we're probably going to have to transfuse this patient. And maybe give them platelets or even some PRBCs. So we did a type and cross. Everybody familiar with the difference between type and screen? Just going to determine what blood they're compatible with. A type and cross is going to make sure that they are compatible with the units that you are actually going to transfuse. So if you know that you're going to give somebody, don't mess with a type and screen, you're going to have to turn back around and get a type and cross. Again, usually that stroke protocol is going to say, okay, you give me TPA, is there any concern for bleeding, and should send you down a different pathway. Alrighty. So, massive cerebral artery, not candidates for thrombolytic therapy, unfortunately. This is an 80% mortality rate, but these people may need to be a candidate for decompressive surgery. Again, you in conjunction with neurology, and they're like, I think this is middle cerebral artery infarction. That should usually give you an idea, and this is going to be on CT scan, that, hey, we need to get neurosurgery, or we need to transfer our patient because we don't have neurosurgery capabilities at our hospital. So, other type of things that they can make that decision on. They've expanded windows for these, how they can treat them, so they're not a candidate for thrombolytics. We can go in and do all these endovascular therapies. Just be aware, yes, they can go in there potentially and inject a thrombolytic directly into the clot. They can remove that clot, bunch of different things. So that mechanical clot disruption, and not spend a lot of time on studying this slide, but just understand that there are other capabilities, but that's provided you have a neurosurgery team in the house. Anybody have any idea how long a residency is for neurosurgery?
7 years?
8 years. That's a long time to be resident. That's terrible. I bet you probably live in a big house, right? Totally worth it. Totally worth it. Obviously, we're going to admit all acute stroke patients and hopefully 2 monitor care units. Keep in mind that some of these smaller MTFs, community hospitals, you're probably going to be transferring these people to somewhere bigger. Just be prepared. They're going to say, hey, if we can't handle this in-house, where does it go? Places will go in STEMI divert, all that different types of things. BAMC's gone on it before, pretty interesting. So, lacks those resources, just be prepared to transfer that patient. It is possible that you can give them TPA in-house and then put them in an ambulance. Most people don't like receiving patients that way, but if they're a candidate for being TPA within the 3 hours and they don't have any exclusion criteria, and we know that the symptoms have been within 3 hours, and it's going to take them an hour to get to the next place, and we need to push that TPA then and comply safe. Okay? And with that, we will take a break. Okay, try and run it. So my goal is that by the time we finish up next week, that maybe we can cut out an entire block. Everybody's like that, right?
Oop.
Unless you think I'm going too fast. All right. TIAs. TIAs. That's whenever I misspeak, that's what's happening. So it's all good. So this is essentially mimics a stroke, focal, brain, spinal cord, or retinal ischemia without the infarction. So these are just precursors. We use that term analogous to unstable angina, and please pronounce it that way. I hear it pronounced incorrectly. It's angina. Doesn't rhyme with anything else. Again, there's the risk factors associated with that. So high blood pressure, diabetes, we talked about those types of things. Symptoms usually greater than 10 minutes. Weakness, speech impairment. I showed you that lady with that headache that had that horrible dysarthria. I would have considered that probably like a stroke, but whatever. When we talk about this, what is also synonymous is what we call an ABCD2 score. So what does that stand for? Age, blood pressure, clinical features, duration, diabetes. This gives us an idea. You should take every person that has TIAs, use this as a decision-making tool. If I'm going to say, I'm going to send you home, well, I better have an ABCD2 score of 0. I better have an ABC2 score of 0. So greater than 60 gets a point. Blood pressure greater than 140/90 gets a point. Clinical features up to 2 points if they have unilateral weakness, or if it's just speech impairment without unilateral weakness, that's only 1 point or 2 points there. Duration up to an hour, 1 point, over an hour, 2 points, and then diabetes plus or minus 1 point. So total score of up to 7, and here does that work out. This is your decision-making tool. If this person is high enough, I'm going to tell you right now, so 2-day risk, 7-day risk. Okay, right now, anybody over a 3, I'm going to be working to get them admitted if we're not looking at risk stratification. I'm going to be working and say, hey, I got this person down here, sounds like you've been having TIAs, and I have an ABCD score of 5. That should be it. They'll be like, I'll be down right away. They need to come in and get worked up because they're potentially going to have a stroke in the near future. So make sure that we do a good physical exam. Make sure that we are going to do full neuro exam. We do want to get an EKG because that's risk for atrial fibrillation. If they have atrial fibrillation, they're a higher risk for having TIAs. And then, of course, we're going to get a CT to make sure we don't see anything there. And we made that person likely admitted. They're going to need a full stroke workup. That's going to be imagery of the carotid, usually via ultrasound, looking for any clot formation. We're going to get an MRI, looking for any vasculature that's specifically in the posterior areas. So, and an ultrasound right there. So if that Doppler is concerning, it's definitely going to warrant a MRA or a CT based on the availability. How do we treat this? Yes, we reach for aspirin, but the first choice for this with TIAs, you need to know this will probably be on your pants. We are going to add diphenol. So shown to prevent vascular events better than aspirin alone. We're giving them these dual therapy. And there's potential, if they are allergic to aspirin, then we reach for the clopidogrel, aka Plavix. So past, this is old school warfarin. Warfarin's kind of really gone away. Warfarin's gone away for the most part. They used to have warfarin clinics where they had to check people's INRs all the time and tell them to tweak it. You got to lay off anything that has high vitamin K, which is usually leafy green vegetables. Anyway, we want to make sure if we do find that they do have some atrial fibrillation. Now, a lot of these people, you may catch it that day, you may not. It's something called paroxysmal atrial fibrillation, meaning it comes and goes. But if they do find any of that, then anticoagulation should be started in the emergency department. Yes, does that run them higher risk if they fall down and hit their heads, if they're going to get a bleed? Sure. They're willing to take that risk. I just make sure, my patients leave the ED, they're wrapping bubble wrap. Just kind of kidding, you can't do that, but there is that risk. But it's more of a concern with treating that atrial fibrillation, telling them to be very careful. Let's get into some special populations. So, unfortunately, sickle cell disease, this is where we do see ischemic stroke in kiddos. Ischemic stroke, as well as different aneurysms and arterial abnormalities. So very similar. We want to make sure that we're treating the underlying sickle cell disease, putting them on oxygen, hydration, and usually pain control, that pain crisis that we deal with sickle cellers, make sure, and then hopefully you have a hematologist and a stroke neurologist that you can get in touch with to advise you on what needs to be done. Yes, and this does happen in the pregnant population, so increased risk of both ischemic and hemorrhagic stroke during pregnancy, and also in the postpartum period. So just because they delivered a baby doesn't mean that they're a less risk, so up to 6 weeks. So especially if they had a history of preeclampsia or eclampsia, which puts them at higher risk for hypertension, and we worry about our people that have diabetes, sickle cell, as well as drug abuse. And then anybody that has had a history of venous stasis, edema, or hypercoagulable state. So far greater during the 6 weeks postpartum than during pregnancy. So just remember, after that, they can also be at risk for eclampsia up to 12 weeks after pregnancy. But just remember, up to 6 weeks is higher risk than the entire pregnancy. So can we give TPA in pregnancy? Yes, we can. It does not cross the placenta. It does not cross the placenta, but make sure, please, that you're involving all the necessary consultants. I would say make sure you load the boat. Loading the boat includes the OB, a neurologist, and probably a neonatologist if you have one of those. BAMC does, but can't say for each of your MTFs. Questions right now? I'm going to go back because stroke's very important. I have some recap notes just to give you an idea for you to run through your processes. And just look through those as you study. Questions on strokes? This one should be an easy one. There's only one thing on that choices that I even talked about. Like I told you, if we're having symptoms that are messing with vertigo, ataxia, dizziness, nausea, vomiting, that's going to be more of a posterior type of stroke. So we could rely down to vertebral artery, posterior artery, or cerebellar infarction. Cerebellar infarction, C is your what? So I didn't really talk about anterior cerebral arteries because those are just like, that's like 0.4% of, that's a zebra. We don't mess with zebras. You could say, well, anterior communicating, we talk about that, so we can take those off the plate. I'm just telling you this is like good test taking skills. That's how you're going to have to figure things out with advanced. You're going to get down to 2 and then flip the coin a couple times at least, hopefully not too much. So posterior cerebral artery, you could make a case that that's what's going on. And you can make a case that it's middle cerebral artery, just the fact that it's the most common. But that's not because middle cerebral artery is going to be affecting limbs. We're not affecting limbs at all with this. So you can make a case with posterior, but this is going to be the vertebral artery. Vertebral artery. It's running right by the vertebrae. So it's going to be more posterior. And we're going to have those types of symptoms. Unable to tandem walk, having ataxia. Ataxia. Ooh, this one gets rough. What I need everybody to pay attention to, what is going to be the first thing that's going to prevent us from giving thrombolytic? Time. Time is going to be the first thing. We can affect the blood pressure, but time. So let's say that I switch that out in this patient's within 5 hours. Oh, then they're no candidate for thrombolytic, but this is 2 hours. So what are we going to do?
Hey.
We need to lower that blood pressure because we need to get it at least 180 over 110. So let's get it lowered to 180 over 100, and then let's push the TPA. A. A is your answer. Good on that?
Ooh.
If they're not a candidate, most of the time they're not a candidate, it's going to be time. And then if we can't lower the blood pressure. And then, oh, wait a second, you had a hemorrhagic stroke? Ooh, yeah. So I would say time is going to be the #1 factor. And if it's time, we're going to give aspirin and permissive hypertension. Keeping that top number below 220, okay? This is just a repeat. It's just a repeat. Same type of question I had before, just changed up. Keep in mind, don't, when you take the test, please don't feel like, oh, I remember that one exactly. But there's not going to be exactly. Maybe some. Maybe some. Oh, he's bamboozling me again. Playing games. Obviously aspirin, right? Okay, last known when they went to sleep. You good on that? All right, precursor for, see if this works. There we go.
Next up, we head to the skies above Perth, Australia, where a routine student skydiving jump turns into a nightmare. This incident was captured on the skydiving instructor's helmet cam. This 22-year-old skydiving student is about to complete the 5th stage of his free fall program.
Thanks for being a fan of Rescue Cam. Subscribe to A&E for more videos and
There are different rules in Australia for
That sucks.
why people do that. That's your precursor for getting into seizures. Definitely will not get through this. This is a whopping 77 slides, so seizure is a pretty important type of thing because it's my process. So my quick, I'll save it for when we get to the actual slide. I had some interesting stories that relate to seizures. So not related to itself, but it's a significant emotional event for a parent. I'll tell you right now, kids have febrile seizures. They don't need to be as concerning, but everybody says that a seizure lasts a lot longer than they actually think because they're not looking at their watch the second that happens. But rightfully so, the biggest thing you need to do with a person with a seizure is make sure they're not going to hurt themselves. Don't fall down and hurt something. There's your reference material. It's about 5 pages on seizures. Just some visual type of stuff. So Why do I show some of these types of things? Just to kind of clue you in with what people think seizures are, and also two different things that I always look for when somebody thinks they had a seizure. I'm going to look to see, did they do any tongue biting? And sometimes they'll bite their lips. So bitten tongue is an idea of a seizure. And then you have somebody that has had some injuries. Okay, so let themselves, they lose control. That's like a dead giveaway. I don't think I've had somebody I've treated for a seizure that didn't piss their pants. So, and it's not like Billy Madison. It's not cool. Alright, I'm gonna stop saying jokes with you guys. I have these like strategically planned, okay? I know it's dad stuff. I've got the best dad joke awards numerous times with Boy Scouts. Anyway, there's your objectives. Here's your objectives. So what I want you to pay attention to or get into is it doesn't get too serious until we get into status. Status epilepticus is when it starts getting scary. When it starts getting scary. But make sure that we're going to pay attention to neurocystosis, pregnancy, alcohol withdrawal. Those are all people that are high risk. Here's your pearls. Most seizures stop spontaneously. So luckily with that guy, they did. I mean, that's crazy, but if we go more than 5 minutes, it's not a quick, it's going to stop. So protect them from physical harm, stop the seizure. In the emergency department, somebody comes in seizing, they usually have pads that they can put on the side of the gurney so they're not like smacking against it. If you're a low budget hospital, somebody just comes in and like tapes towels to it. So benzos is what we should be giving. So a lot of times that has been given usually in the rig if they're coming in by EMS. Moving stepwise, and we'll go through that. That's some nice charts that show you how to do that. So make sure, so seizure is typical in a patient with known seizure disorder. Somebody has known epilepsy, very common that they're going to come in, but if they don't have a seizure disorder, we need to be very concerned that there's a secondary cause. That can be anything from poisoning to a brain tumor to meningitis, needs to be worked up as such. I had an interpreter who was sick, like a viral illness, and then the next thing they bring him into me in Afghanistan, and he's full-on seizure. It ended up being meningitis. And air was red, so it was a wonderful time. You know, we got him taken care of, and then he wanted to come back. I had to vaccinate all the other interpreters, and they wanted to come back and work for me. I was like, no, he's not going to come back in the cop. It scared me so much. Just keep in mind, this can be misconstrued. Some people consider this a cardiac event. Sometimes syncope can present like that. There'll be kind of some agonal type of twitching. Don't be worried about that. But we need to be worried about our pregnant patients. Also, our HIV/AIDS population can be very challenging in a serious type of deal. Warm it up, Chris. What are we going to get on this patient first? Absolutely. And why do we get glucose? Because I need to know, are they having a seizure because they are hypoglycemic? Or are they now hypoglycemic because they have a seizure? Boom, I'm going to get that, and I'm going to order a phenytoin level in their known seizure disorder. As long as they return to baseline and we have no significant injuries, I'm probably going to discharge them with that phenytoin level and tell them to follow up with their neurologist. As long as they are known seizure disorder, and it's like, yep, I have a normal seizure, and have them once a week just have a breakthrough seizure. Well, they need to see the neurologist. I'm not going to treat their medications. I'm not going to add anything. I may pick up the phone and call the neurologist and say, hey, they have a seizure again. Glucose is fine. But phenytoin level, just follow up on it, call them. That's known seizure disorder. Okay, somebody that we don't know is unprovoked. That's a whole different role. Okay, seizure, uncontrolled electrical activity. So usually muscle tone and movements, hence the tonic-clonic. And there can also be some behavior sensations and state awareness as well. Most of these people, if you've ever seen somebody have a seizure, they have no clue. They are post-ictal. Zero clue. They are wiped out because they just worked their body out for like 2 minutes straight. So they are wiped. Mild is pretty common, but they're completely post-amnesia. So epilepsy, recurrent seizures, these are known seizure disorders. Known seizure disorders, usually a lower threshold is related to that. But epilepsy, if we know that there's reversible causes, there are secondary causes of that, it's not epilepsy. Epilepsy we don't know. So if it's worried about alcohol withdrawal is probably the biggest one that I get concerned about, which is why we put people on CIWA protocol, CIWA, in the emergency department, just to watch them and start getting a little bit of delirium tremens. So worried about toxins, again, that hypoglycemia. So people that have pancreatic tumors that secrete too much insulin can cause hypoglycemic seizures and metabolic derangements as well. There's your primary idiopathic. Those are the ones which we have no cause, and then we have our secondary. So that is a picture of neurocysticercosis. So I would pay attention to that picture. Okay, if you saw that on CT scan, you need to know there's probably a person from a third world country. Those are secondary related. They can also have lesions. They can also have a head injury or a stroke. And then there's reactive. Reactive usually relating to medications, and it's always a black box warning on some antibiotics that can cause seizures. Not very likely, like sharp blow to the head. So not considered a seizure disorder or epilepsy. That is reactive in nature. Then we want to make sure, was it provoked? Meaning there was some type of precipitating event or unprovoked. And our status epilepticus is seizure activity going greater than 5 minutes or greater than 2 minutes. Greater than 2 seizures without regaining consciousness between the seizures. And actually return to full consciousness. And then for refractory status epilepticus, we've given 2 different medications, not 2 doses, 2 different medications, and they are refractory. That's when it gets very concerning. It's refractory. For the visual folks, here's the breakdown. So we have our generalized, which forms up tonic, clonic, and absence, also known petit mal and grand mal seizures. And you have our simple, these are all partial, and there's complex, and there's partial, the second generation, that's the Jackson March. Jackson March right down there. It only occurs on one side of the body. So, a few seconds, not very common, but just beware. And then we have the mild clonic, tonic, and clonic, and then atonic. So, not going to really get into the others category. We're really going to focus more on the generalized and the partial. So here's your tonic, clonic. This is what you probably see on TV the most. And this is going to be most commonly what you're going to see coming into the emergency department. This is affecting the entire cerebral cortex. So abrupt loss of consciousness becomes a problem. The person decides to start seizing while they're standing up. Which is why we have to be evaluating these people for orthopedic injuries, or head injuries, or tongue injuries. So clinical manifestation. So most of the time that's at tonic-clonic. That's a rhythmic jerking. I'll show you in this next slide here. So you can see what that clonic is, that tense, tight, whole body's tight, and then clonic phase where they actually start twitching. So tonic with rigid, clonic increasing course trembling, usually symmetric, rhythmic jerking, and it could include the trunk and the extremities. What's concerning about this is a lot of these folks go apneic. Apneic when they go out, they go very shallow breathing, and very concerning. Not apneic period, you can get sometimes cyanotic, very concerning. Possible they can vomit, they can aspirate, but most of the time they urinate. As that attack ends, they're going to go flaccid, they're going to be unconscious, usually for about 60 to 90 seconds. Consciousness is going to be very slow. They're going to be post-ictal. I'm going to tell you it's going to be probably about 15 to 30 minutes before they're going to be able to tell you where they are and what their name is. It's very common and a giveaway for that post-ictal confusion. Myalgia is when the body is doing that tonic-clonic action where it's tight, rigid, and then it starts jerking. It's like a workout there, and it's white, very white. So you usually can go on for a couple hours. Clarion grand mal, you get that? It's your typical versus your absent seizure. These are very interesting. No change in postural tone. You have to worry about these people. They can have the absent seizures, just be there having it. It's going on for a few seconds. They do not fall down. They do not go tonic-clonic. So they may look like they are just aloof and they're not sure what's going on. There's possible staring, twitching of the eyelids as well. They are not going to respond when this happens. So there's potential for some slight involuntary movements, and there's potential for them to become incontinent. But usually no post-ictal period. Where does this category fit? This is classically in school children, where they usually touch that on. So they're like, anybody been driving along the road and like long road trip, and then all of a sudden you realize you're driving? That's the order something. And I could write the shit out of this. Anyway, that's what I would say. You know, they don't call them that in older folks, but in kids. And what does it usually show up? These kids are just doing very poorly in school. Very poorly in school. And this can happen as many times as 100 more daily. So you're poor in school, but it usually resolves. On its own. So if it's adults, we're going to call it complex partial seizure. Complex is more likely to be that. We don't call it absent seizure because the treatments would be completely different. So again, if it's an adult, you worry about something you don't call it an absent seizure, you're going to call it a minor complex partial seizure. So here's your partial focal seizures, usually localized to a certain region of the brain. So, but it can spread and go from a simple partial focal to something more. But the concern with this is we need to be very concerned that there is a localized structural lesion of the brain, aka some type of space-occupying lesion that can be anything from a tumor to arterial venous malformation. Those are going to be probably the biggest types of things. So it can mimic a generalized seizure, but usually that has to be diagnosed by EEG. Versus your partial simple right here, conscious and mentation are not affected. Seizure remains localized, it does not spread. So based on where that is happening, so tonic-clonic movement to one extremity, we're concerned it's in the motor cortex. Visual symptoms, it can be an occipital focus. And then if these people have smell and taste, it's likely in the temporal lobe. So usually aura, these people are going to know that's going to happen. So simple. Now here's your partial complex. These are the ones that are very, very interesting. These are commonly misdiagnosed as psychiatric problems. Why? So consciousness and mentation is affected. Usually is a temporal lobe seizure. Usually starts in the temporal lobe. Again, this is misdiagnosed as psychiatric because these symptoms are very bizarre. So they do call it psychomotor seizures. And I'll tell you why it's bizarre. It's because it's going to look like this. So if I give you a test question and somebody's acting weird and not responding very well, saying some outlandish stuff, and they're having lip smacking, fiddling with clothing, most of these people are like unbuttoning and buttoning or zipping and unzipping like nonstop. They can also complain they have just kind of butterflies in their stomach, but then they can also have these wonky hallucinations, anything from visual to auditory to taste and to smell. So those are what I want you to take away from that. What's this when I say hallucinations? We're talking about most commonly a metallic taste is what they'll complain of afterwards. So clinical features. All right, you're going to ask yourself right away, is this a seizure or is this a mimic? Because you're going to have a lot of people say, he had a seizure, that's just what they saw. A lot of times people pass out, they syncopize, vasovagal, it's normal for them just to twitch just a little bit. Misconstrued, want to make sure that hopefully somebody was there and can tell you how long they were seizing for and can describe that attack. Again, parents that have kiddos that have had repeated seizures, I'm like, please pull your phone out and bring me some video. bring me some video, bring me some what you're seeing, because I don't want to get it mislabeled. So mimics, syncope, sometimes arrhythmias, something called pseudo seizures, which I've seen are migraine variants. So, and then what we call myoclonic activity. Everybody, you've been sleeping and like you suddenly wake up and you feel like you're falling.
Yes.
Somebody's watching you. That's a seizure. Want to see if they have any aura, that feeling or experience that movement that's going to happen before. Was it abrupt? Was it gradual? Where did it start as far as muscular or motor activity? Of course, loss of bowel or bladder almost every single time. And then you want to make sure you're looking in the mouth. Did they crack any teeth? Did they bite their tongue? Did they bite their lip? So the duration, and then of course, post-ictal is usually a giveaway. Now, if they're known epileptic, you want to make sure, hey, is this changed from when you have your seizures, your baseline activity? If it's changed, we need to kind of figure out what's going on, and that maybe deserves a workup. If they're saying, yeah, I've not had a seizure quite like that, not had a seizure quite like that. So, and then figuring out what was the precipitating factor, and here are most of those factors. Number one, missed their medication. It's usually younger patients, not older patients. And then do we recently change the medication? Do we lower it? Do we increase it? Sleep deprivation is a huge precipitating factor. I wouldn't pay too much attention other than, yes, I'd be concerned about the last three on this list because those are secondary causes that happen with that, and worry about an underlying meningitis, worry about what type of electrolyte disturbance is happening, and then any type of substance or alcohol use. And then no previous history of seizures. We need to work up a little bit more. Some people can be seizing in their sleep and have no clue that that's going on. So that's why we want to see, hey, have you had any unexplained injuries? Do you wake in the morning, you bit your tongue? Have you been wetting the bed out of nowhere? Those are all types of things that give us an idea of maybe they are seizing while they're sleeping. So if there's headache associated with that, we need to be very concerned as well that there's some type of pathology going on in the brain. And then pregnancy or recent delivery, postpartum, we get concerned of eclampsia. Now eclampsia, book answer will tell you 4 weeks. I've had OBGYN docs say they've seen that out to 13 weeks. So just an idea of that. So usually half during pregnancy and the other half are postpartum. Again, you get the glucose. Was it the cause of the seizure, or do you need to fix it after the seizure? And then we want to make sure they're checking for these particular injuries, the head or spine, because typically somebody doesn't know or never had a seizure before, it's just going to fall on the ground. So posterior shoulder dislocation is going to be your pants answer of most common type of orthopedic injury. But make sure you look in the mouth, and then potentially do we need to shoot chest x-ray to make sure they did not aspirate. Not that it's going to show up much if it just seized, but you might want to check at least at that baseline. Complete neuro exam, absolutely. So, and then you want to make sure checking for the patient's loss of consciousness, mentation. So we want to make sure that's that non-convulsant status epilepticus, which means they seize, but then they never fully wake up. They're not post-ictal. We have 30 minutes. Who are we calling to get a stat EEG? Okay, outstanding. And then just be aware there's also the symptoms paralysis, which is this focal neurological deficit that occurs for about 48 hours after a seizure, usually a simpler complex focal seizure, but that's usually not described as epilepsy, should resolve on its own. Now we need this diagnosis. Of course, we need to have that sudden onset and then sudden termination. And in the post-ictal state, these movements are purposeless. Hopefully somebody took some video, but that's not always possible. And that post-ictal confusion and lethargy, you're not going to see that in your simple absence attacks or simple partial seizures. They should have amnesia from that entire event. They have no clue what this is. No clue. ensure that it's not syncope. So syncope usually is going to have some prodromal symptoms, unless it's a cardiac syncope. We'll get into that next time. But with that, we're going to see some lightheadedness, some diaphoresis, nausea, what's called tunnel vision. Cardiac syncope, we need to be concerned if that person syncopizes. So that is cardiac syncope, is grandpa's at dinner and suddenly his face is in the mat potatoes. Like, that's not good. That means there's probably a heart issue that's not perfusing to the brain. So you can sometimes see a little bit of incontinence with that, and brief tonic-clonic, but there's going to be no post-ictal state. No post-ictal state means no seizure. Now, pseudoseizures, very interesting. These are more psychogenic in nature. There's underlying psychological issues that's going to be addressed. Usually conversion disorders, panic disorders, psychosis, impulse control, Munchausen syndrome lingering. These people can protect themselves from any noxious stimuli. All right, you ready for a story? Here it goes. So I'm on my neurology rotation up at Eisenhower, and I show up the first day, and a young specialist, and he's all hooked up with the EEG, the neurologist. Know anything about EEGs? I was like, nope. Probably shouldn't have not said that, but whatever. But the guy's just twitching away. And he goes, it's a normal EEG. And I'm like, what? Why is he doing that? He goes, I'll tell you in a minute. So unhooks him, he keeps twitching, walks into the waiting room, twitching away, and he's like, he has pseudoseizures. I'm like, okay, cool. He goes, watch this. He goes over, picks up his phone, calls the dude. And that's twitching away. Phone goes off, picks it up, stops twitching. He goes, hey. He looks over at us. No shit. That dude followed me to my very first duty station at Fort Bliss. I decided to walk into my clinic and have another pseudoseizure. I looked at the nurse practitioner, the psych nurse practitioner. I said, pseudoseizure, have a good day. I'm not messing with this again. Shit, you not, though. So migraine on your differential, so aura similar to seeing that, but again, we're going to see that scintillating scotomas, that's little dark spots, that are little tiny blind spots that are spinning around. So usually have focal neurological symptoms. We can have some hemiparesis with this, as well as that hemoptysis that I showed you. So active disorders can be inconsistent with the migraine if it is a seizure. What do we do with our labs? So what I see in a patient with a well-documented seizure disorder, that was your warm-up case. We're going to get a glucose level and any anticonvulsant medication levels. Those are all send-outs. You figure out what they're on, whether that's phenytoin, phosphonitoin, levetiracetam is probably one of the more common that I see. That's Keppra. So make sure we get those ordered. If it's not that, if it's their first seizure or the change of baseline, then we need to go ahead and full Monty that. So glucose, basic metabolic panel to make sure that we are getting at least those electrolytes. You have to add a calcium in the mag. Let's get a lactate, because if somebody's been seizing for a very long time, they're going to have some level of ischemia, and we need to make sure that we clear that with fluids before we get them out of there. So, and then HEG, if it's a pregnant patient, absolutely, or a patient of childbearing age. And then there's always potential to go ahead and get tox studies, especially in kiddos. And I'm not saying that kiddos are running around doing drugs and stuff, but little kiddos like to taste test things. Some pill or something ended up on the ground or something else, and that's the potential for that. And if they come up positive, that's an automatic call to CPS. Automatic call. So lactate driven, that's why we get that. So it should usually clear within 30 minutes. So other places like to see a prolactin level. If it's unclear if they're post-ictal or they had that seizure and they obviously returned to their baseline and we're not sure, a prolactin level will be elevated, but usually only 15 to 60 minutes after a seizure. So you distinguish true seizures from pseudoseizure. I really hope they figured that boy actually out. That still irks me. Anyway, head CT. Like I said, first ever seizure. We want to give these people the full Monty. We need figure out, make sure there's no secondary causes to that. No secondary causes. It's not normal. We want to rule out a structural lesion, get that CT scan. So it's important to get that imaging. So, other types of x-rays, yeah, we may get a chest x-ray if we're worried that they vomited and aspirated. Maybe you just want to make sure that it wasn't a seizure brought on from infection, so looking for pneumonia. And then you may want to get a shoulder x-ray just in case if you're worried about any type of dislocation. But a dislocation could be pretty easy because they're not going to have full range of motion. So if they fell from standing, definitely get a CT of the C-spine. I would probably just go ahead and get a CT of the head and neck at the same time. And then there's your chest x-ray, reasons, and your shoulder radiographs. The lumbar puncture, if they are febrile, definitely if they are immunocompromised, or if you suspect a subarach with that normal head CT, hopefully within that 6 to 12 hour mark. We're looking to go through that. By the way, I did mention you know that, right? 6 to 12 hours for CT? Yeah, I would know that for sure. And then reaching for that, EEG, usually not readily available, but maybe they're there long enough you can get that done. That's worried about that non-convulsive status epilepticus is what is going to be the proper answer for that guy. So usually you call neurology down, they make the decision. They may say, you know, we're just going to admit the patient, we'll take them upstairs and get the EEG done. They're willing to take the patient. Once they're out of your ED, they're not your responsibility anymore. All right, treatment. So again, if it's not much to do during that initial attack, most of them should resolve on their own. We want to make sure that they're not going to hurt themselves. So obviously, if they're not standing anymore, you want to put the patient on their side, aka recovery position. Make sure that they don't aspirate. And then you want to clear that airway because most of the time they're clenched up pretty good. They're apneic. So we don't usually need to reach for medication in an uncomplicated seizure. Again, most resolve within 5 minutes. Over 5 minutes, we're in status. If we have more than 2 and they don't return to baseline, in between those seizures. So, patient had a adequate anticonvulsive level, not likely that you will be following up on that single attack. And these patients occasionally have breakthrough. So you just want to make sure that we figure out if there's any precipitants that we can help out though, but usually it relates to changes in medication, missed dosages, sleep deprivation. But again, what I want you to be worried about is those last 3. So I'm going to be concerned if there's an underlying infection that's causing these seizures in our first time seizure, folks. If there's any abnormalities with lights, that includes calcium and magnesium. And then I'm worried about substance withdrawal. And that's a tough one because people are not typically very honest about that. So, first unprovoked seizure usually does not require hospital admission, and we usually don't just start them on a medication right off the bat. But what we do with these first-time seizures, provided they return to baseline and all their labs and their entire workup comes back completely okay, we do have to say, you can't go driving and you can't go swimming until you're cleared by a neurologist. You're going to have to write a profile that says that. Not just like a 3-day profile, like, no, you don't drive. I would add that I would probably not go anywhere near heights. And I probably wouldn't want you doing anything heavy machinery-wise. But the book answer is no driving, no swimming, provided the workup is normal and the patient returns pretty much to baseline. So usually defer to outpatient setting because they're going to get an EEG, they're probably going to order an MRI. That's going to be more of the workup to make sure there's something else going on. Keep in mind, if that person has other underlying factors, aka they're handicapped, they have poor social standing, meaning they don't have the money, they don't have health insurance, they're going to be lost to follow-up, there's potential that you need to admit those people for their own protection. So you can identify that cause. So we treat it, we identify it, we admit them, and then usually going to get them medicated to reduce any recurrence. So instruct patients don't take risks. So again, hazardous tools, machines, working at heights. Driving, strictly prohibited. The book answer says primary care manager, I'm going to want them to see a neurologist. If they have a seizure, they need to see a neurologist. So, most primary care managers are not really super in tune with exactly, or have the resources to get them an MRI and EEG as quickly as a neurologist will. So, again, secondary causes, or it's uncontrolled seizures, we need to get them admitted, we need to get them figured out and taken care of. Special populations. So, special populations specifically dealing with these types of things. These are some underlying issues that people that are immunocompromised deal with. So mass lesions, encephalopathy, herpes zoster, toxoplasmosis. Not just because they're hanging around with cats or litter boxes or whatever. These people are just immunocompromised and run a high risk for all that stuff. I'll tell you, every person I saw with HIV at Harvard View that came in with febrile, I got to do an LP on. So I want to make sure CT scan, no evidence of increasing your cranial pressure, go ahead and get that LP knocked out. Again, because they have HIV, we have to get the CT first, right? Because we're worried about herniation. We talked about that before. So potential, if we can't figure that out, they need to come in. And then we've got our pregnant patients. So most seizures in pregnancy are not first-time seizures. It's usually happened multiple times. Most of the time it was probably while they were sleeping. So beyond 20 weeks of gestation, in the picture, they're going to have increased blood pressure, edema, and if you do a UA, they're going to have proteinuria. That is defined as eclampsia. If they have eclampsia, we treat it with mag sulfate, eclampsia, seizures. So what else can we treat with mag sulfate? Rhymes with borods, torsades. There we go. All right, and then you worry about your alcohol use, folks. And you want to get on top of this before. I don't like letting them get to seizure world because what you're going to treat them with is benzos for the most part, or Librium. That's going to prevent the seizures, going to help them out. It's going to ease them out of that very tremulous alcohol withdrawal seizure. So benzos, and with that, I like to get ahead of the game before they actually start doing that. And doses can obviously be very large based on how much they drink. So, treat the alcohol use in the patient, first time seizure, definitely. And then, we're going to go ahead and stop here because I don't want to do any status because this is where the money happens. So, if you guys finish up early again tomorrow, I'll be ready to